Hello, everyone, and welcome. I'm Shelley Gunther, Clinical Marketing Manager at Clarius. Thanks so much for joining us today for this live webinar event. We've had so many requests for educational content geared toward podiatry, so we're excited to be able to offer this one titled POCUS Essentials in Podiatry, Enhancing Foot and Ankle Assessments. You're among just over 2,100 who registered for this popular session. Welcome, and thank you for joining us from all over the globe. It's been wonderful to partner with Sonoskills once more to bring you today's educational event. In a moment, we'll be joined by renowned educator, Mr. Mark Schmitz, who will teach us sonoanatomy, teaching us his scanning skills and pathologies that you may come across in your practice. Now, a quick housekeeping note, please use the Q&A icon at the bottom of the screen at any time during today's session to ask any questions, and we'll address those in the live session close to the top of the hour. There's so much great content here, and if we get lots of questions, we may go over the hour. So after that, I'll be introducing sonographer Janae Smith in a little while, and Janae will give us a live demo after the presentation. Now, neither Janae or I have had much experience in scanning the foot, so working on this webinar has been a real valuable learning experience. Now, before we get on with the presentation, I'd like to review some literature I came across when putting together the abstract for this webinar. And now, this first paper is from the Journal of Foot and Ankle Research, and the aim was to further investigate the use of musculoskeletal ultrasound by podiatrists within their clinical setting and gain insights into the impact that they perceive the use of musculoskeletal ultrasound has on their approaches to management of MSK foot and ankle problems. The perceived benefit of the 232 podiatrists who participated was an improvement in the patient journeys through tighter focused management plans and reduced waiting times. Additional novel finding was that ultrasound provided the capacity for podiatrists to better inform patients of their diagnosis, which they believed led to improved engagement and consequent empowerment of patients in their treatment plans. And on the next paper, although we won't be covering this topic specifically, I found this interesting in that it shows the expanding uses for ultrasound in the podiatry world. The authors found that the podiatrists with ultrasound experience were able to identify and describe characteristics of diabetic foot wounds. And this may translate into the development of protocols and training material for further use of ultrasound in this application, as well as other wound types. Now, just a quick poll before I introduce our guest speaker. What do you perceive as the benefits of using ultrasound in your practice? Now, please choose all that apply. Are you just looking for improved diagnostic accuracy, better patient outcomes, or even if you don't use ultrasound, you can answer that. Let's take a second to close out the poll here. 3, 2, 1. Excellent. Okay, so mostly improved diagnostic accuracy and improved efficiency in treatment. That's great. Okay, so you're going to get some really good information from this webinar. So now I'd like to introduce Mark Schmitz, founder and CEO of Sonoskills, joining us from the Netherlands. Mark is an expert in the area of MSK ultrasound, so much so that he began developing his own courses, and Sonoskills was formed in 2010. They are now a team of 22 expert trainers and have taught courses in 30 countries. And besides managing Sonoskills, Mark teaches the foundational courses and some intermediate level courses. I am a huge fan of Mark and Sonoskills and all of their teachings. So at this point, Mark, I will hand the presentation over to you.
Well, thank you, Shelley, and of course, Clarius and Janae for inviting me once again. It's a pleasure being here. And today we're going to speak about musculoskeletal ultrasound in podiatry. And of course, the foot and ankle is a very fascinating region, also sometimes a little bit difficult with all those little structures within. And ultrasound can be of help in patient care, diagnostic, but also interventionally. So let's go into the presentation. So today's PowerPoint deck can be downloaded if you go to sonoskills.com/handouts, or if you scan this QR code, then you can download the handout of this presentation. We have a number of topics today to discuss, and we're going to start with the plantar fascia. So the plantar fascia starts at the level of the heel and then goes all the way to the forefoot. And especially in this heel region, we are going to discuss today how to scan it. And we know that the plantar fascia has multiple branches and parts, and especially the medial and the lateral, the medial and central part, they are thickest and they deserve our attention. So we are going to place the transducer on the heel, as you can see, in a longitudinal plane. Please observe my knee, which holds the foot into a dorsiflexion, and with this dorsiflexion the plantar fascia comes on a stretch, and with this stretch it's better to visualize. If we are going to scan this plantar fascia, then this is the anatomy we will be seeing. We will see the heel bone with attached to it the plantar fascia. On top of it, we see the heel fat pad, and underneath the plantar fascia, we will see the flexor digitorum muscle. After having checked it longitudinally, we're going to turn the transducer in transverse, and then we're going to scan over the heel, look at the bone, and also look at the plantar fascia for its thickness and also its appearance, its ultrasound appearance, its echogenicity, and to see whether there are thickening or maybe some lesions. So here we can see the transverse view of the plantar fascia, and on top of the bone there you can see the plantar fascia thickness. So this is the width of the plantar fascia, this is the thickness, and you can see that the plantar fascia is nicely hyperechoic, and this is important. So let's have a look how to scan it. Placing the transducer on the heel, you can see the marker indicating the calcaneus. It should be smooth, so we should not see any cortical irregularities. Also no pointy edges, that could be a heel spur. And then there you can see the thickness of the plantar fascia. It should be straight, the plantar fascia, or horizontal in screen. And we're going to observe how thick the plantar fascia is over all its stretch. The plantar fascia should be hyperechoic. If it's dark, that could be a reason that could be due to swelling. We're going to slide the transducer from medial to lateral to see every fiber. On top of it, we can see the heel fat pad and also the skin, and underneath, like mentioned, the flexor muscle. So here you can see my hand moving medial to lateral to look at the bundles of this plantar fascia. Then we are going to turn the transducer in transverse view, and starting at the heel, the calcaneus, with a very thin layer of plantar fascia on top of it, and from there on we're going to slide to ventral, and looking at the fibers in a transverse view. So if we are discussing injuries and see how ultrasound scores in assessing those injuries, then ultrasound scores a 3 for plantar fascia, and 3 is the highest in this ESSR consensus statement, meaning that ultrasound is the preferred imaging technique. 2 would be ultrasound is equivalent to other medical imaging. 1 is ultrasound is less favorable, and 0 is please don't do any ultrasound. And in this case, you can see that we have a plantar fasciitis. There is a thickening of the plantar fascia. You can see that the plantar fascia is also more convex, and also here a little bit more, also thickened, round, a little bit of a concave view. And this is due to softening of the plantar fascia, and also therefore this hyperechoic appearance. In transverse view, cross-sectional area, you can see that it is increased also due to the swelling. If you look at the bone, you can see that the bone is smooth, and this is also how it should be. In the next case, however, the bone is not smooth, and that could indicate that there are partial tearing, which with small parts are like avulsed parts are being torn off the bone, and that you can see mainly in the more severe cases of plantar fasciitis. So here you can see the bone irregularity, maybe some avulsed particles, also some calcifications. We see swelling in the plantar fascia. We can see this in both planes, both longitudinally and also in transverse. And there we can also see some neovascularization, which is the combination of neovessels and nerve sprouting, neoinnervation. And this is an inflammatory response, which is not optimal. If we're going to go to the Achilles tendon, it's a small step, but an important step. Then we can have a look at the Achilles tendon, but also at the calf muscles. Here we can see the Achilles tendon. There, again, we can see the origin of the insertion of the Achilles tendon. Then the Achilles tendon goes to proximal. In the depth, we can see Kager's fat pad, but also the retrocalcaneal bursa. So placing the transducer longitudinal on top of the Achilles tendon with the foot still in a dorsiflexion. And this is what we can see. We can see the calcaneus right there. We can see the thickness of the Achilles tendon, all fibers are nicely aligned, parallel aligned. And we observe the tendon thickness, but also the echogenicity, and again, bone changes. But also in this triangular zone here, we can see the retrocalcaneal bursa, maybe effusions can be picked up right there. After we've checked it longitudinally, we are also going to check it in transverse. After this longitudinal scan, we can also see the soleus muscle and the Achilles tendon splitting into a gastrocnemius aponeurosis and in the soleus muscle. So going to a transverse view, then doing the same procedure again, starting at the calcaneus, then moving to proximal, using if this is the Achilles tendon, placing the transducer a little bit from medial, so not really straight, but a little bit more from medial on top of the Achilles tendon for a nice transverse view. So here we can see the transverse view of the Achilles tendon with Kager's fat pad underneath, and look at that beautiful oval hyperechoic structure. So let's have a look how to scan it. We can see again the foot in a dorsiflexion, and again with the foot with the transducer a little bit from medial. Here we can see the Achilles tendon indicated. That is indeed the calcaneal bone. That is the thickness of the Achilles tendon, and look at those horizontal fibers. The bone should be smooth, but anticiphites or maybe some calcifications can exist also close to the bone. This is the retrocalcaneal bursa, which might be filled with a effusion. Right next to the retrocalcaneal bursa, we can observe a large gray mass, which is Kager's fat pad. That is the thickness of the Achilles tendon. We're going to follow the Achilles tendon up to proximal. And in the depth, you can see Kager's fat pad, and one level deeper, this level, that is the FHL, the flexor hallucis longus. Look at my hand there, wiggling the toe, and you can see the flexor hallucis longus moving. And slightly higher, this is a nice point. There you can see that the soleus muscle, well, this is Kager's fat pad, and here you can see the start of the soleus muscle. The soleus muscle flows into the Achilles tendon right there, and as of this point to proximal, we can see the soleus muscle, and on top of that, the gastrocnemius aponeurosis. And that is still the FHL in the depth. Going to proximal, we follow the gastrocnemius aponeurosis. This becomes increasingly thin. The soleus muscle is quite dark. It has a very typical muscle architecture. And at one point there, you can see a triangular muscle starting. This is the medial gastrocnemius, and that is a famous spot also for lesions. So definitely look at this calf muscle, this medial gastrocnemius head right there. You can see also that the medial gastrocnemius has a very different muscle architecture than the underlying soleus muscle. Yeah, that is indeed a famous spot for pathologies. So the gastrocnemius aponeurosis is really thin, going back down to distal, and you could do the same procedure also going towards the lateral gastrocnemius. And we're doing the same thing, also observing those muscle fibers. Looking at the consensus statement of the ESSR, we can see that ultrasound scores really well in Achilles tendon problems, tendinopathy, tearing, calcific tendinitis, but also bursitis. So don't be afraid using your scanner to look at this region. In this case, we can see a swelling right here. There is increased thickening. We also see superficially a hypoechoic change due to a swelling. We can see that the fibers are still intact, so probably no sign of partial tearing, and we can see a mild neovascularization. So this is a tendinopathy, no signs of tearing, so that is okay, but definitely a tendinopathy. A sign of tearing can be seen in this case. We can see a oval, almost roundish Achilles tendon. This Achilles tendon is swollen and shows a large partial tear right there. This partial tear is also compressible. It's not only here, but also at this level. And then we can see softening of the tendon. And this makes also that the tendon is really compressible. So we can see a large, very severe tendinopathy and a large partial tearing inside the central tendon.
So Mark, a normal tendon wouldn't be that squishy, that compressible?
No. So the usual tendon is quite hard and not so squishy, and also not so large in cross-sectional area. Here we can see the Achilles tendon fully torn. We can see one stump right there. This is the other stump. This is the fibular pattern, but that can't be seen anymore in this region due to the degree of retraction. So complete tearing and also neovascularization. And here we can see a retrocalcaneal bursitis with a effusion in the bursa, and also a nice to see as a sonographer, but a severe neovascularization around this bursitis. So from the dorsal ankle, we can go to the lateral ankle, looking at the peroneal tendons. And the peroneal tendons, best to observe starting is in the dorsal malleolar region. There we can find the peroneus longus, which is tendinous, but also the peroneus brevis, which is partly tendinous, but also partly muscular. And these are underneath a retinaculum right there, and also a labrum. We can follow the peroneal tendons all the way to their insertions, respectively at the base of the fifth metatarsal bone, but also the peroneus longus going underneath the foot to the medial cuneiform bone and the base of the first metatarsal. And along the way, we can look at several points where they might be injured near the calcaneofibular ligament, near the peroneal tubercle, or maybe at the level of their insertion. So scanning over it in transverse view, and then retromalleolar, behind the malleolus, we can see the peroneus longus there. We can see the peroneus brevis tendon, and also the peroneus brevis muscle belly underneath the retinaculum. So here you can see the placement on the transducer on the dorsal aspect of the malleolus right there. We can see the longus there. We can see the peroneus brevis muscle right there. And then indeed, they are wrapped underneath a retinaculum. This is the peroneus brevis tendon. This brevis tendon is closest to the bone. And we're going to see if the tendon is located here, or maybe it's luxated. That is a possibility if the retinaculum or maybe the labrum is torn. The longus is furthest from the bone, but due to a pressure, it can split the brevis in two, and then the longus is also close to the bone. From there on, we're going to circle around the ankle joint, and we're going to scan the peroneals near the calcaneofibrillar ligament. This is the ligament right there, and on top of the ligament, we can find the peroneal tendons. With stretching of the ligaments, ultrasound guided examination, you can let the peroneal tendons bounce on the ligament, then you know that the ligament is intact. And from there on, we're going to follow the peroneals until the peroneal tubercle that is at this location, and this tubercle splits both peroneal tendons, where the brevis goes to the base of the fifth metatarsal and the longus goes to the plantar foot. And you always have to tilt the transducer in order to avoid anisotropy as much as you can. But it is very hard to have them both hyperechoic in screen. It's more of a salt and pepper sign. So you can see the one or the other, and with tilting, you can switch between the two of them. Here, placing the transducer and longitudinal over the base of the fifth metatarsal. And there you can see the insertion of the peroneus brevis to the base of the fifth metatarsal bone, looking at the tendon quality, but also at bone quality. So also in case of avulsion fractures, that is easy to see. So also the peroneal tendons, they are really easy to scan with ultrasound being the preferred imaging technique. So here we can see a tenosynovitis. This is the peroneus brevis. We can see the longus in this tendon sheath. Lots of effusion there. Tendons, they look okay. We don't see any signs of tearing. So we can see a nice fibrillar pattern, nice hyperechoic color, and but definitely effusion in the tendon sheath, thickening of the tendon sheath, and also a neovascularization. Here we can see an example of peroneus brevis splitting. This is peroneus brevis, this is the brevis, and this is the longus, pushing the brevis that hard to the bone that in the end the brevis will split. If we go on longitudinal plane, we can see brevis there, brevis here, and in the middle indeed the longus. So if you want to know more on Sonoskills, then you are invited to visit sonoskills.com. We offer all kinds of diagnostic and interventional MSK ultrasound courses, both hands-on and online. So we have an extensive online program, but also indeed many foundational, intermediate, advanced, and expert courses all around the world. So it would be really nice to meet. And one occasion would maybe be a ankle and foot course we will be organizing. This is a 2-day boot camp, and you will learn everything there is to know on foot and ankle ultrasound. You can see the link underneath and also the QR code. So if you can scan the QR code, you can find more information about this foot and ankle bootcamp. So going to the lateral ligaments, we have many ligaments in the foot. Let's pick the three most affected ones. The tibiofibular ligament, the talofibular ligament, and the calcaneofibular ligament. To assess the calcaneofibular ligament, the foot is in a dorsiflexion, and we're going to place the transducer on top of the lateral malleolus, connecting with the calcaneus. And what we will see is the calcaneofibular ligament right here in the depth. And we observe the fibular pattern, but also if we can see any effusions around the peroneal tendons, or maybe effusions from the talocrural or subtalar joint. The anterior talofibular ligament, the foot is in a plantar flexion, a little bit of an inversion, and the transducer is aligned with the plantar foot. And here we can see the talofibular ligaments in between the fibula and the talus. This is, of course, the joint, observing the bone quality, bone regularity, the integrity or continuity of the ligament. Do we see any calcifications or avulsions or effusions? That is what we're going to observe. And if we turn the transducer more diagonally, we can also view the syndesmosis and the tibiofibular ligament, especially if we stress it under a dorsiflexion and external rotation. So in this case, we can see the scanning of the calcaneofibular ligament. This is the malleolus. There we can see the ligaments right there. Try to have it hypercoic in screen. Try to stretch it, and that you can get or make by dorsiflecting the foot. So usually I hold the foot like this. With this, I'm steering the foot to dorsiflexion or inversion, stretching the ligament, and then I can see the peroneal tendons bouncing on top of the ligaments. This is a healthy sign. If there is a tear of the ligament, then you will see the ligaments going into depth, into the defect of the ligament. But you will also see joint space gapping in the talocrural or maybe subtalar joint. So after having done this bouncing procedure, we're going to place the foot in a plantar flexion and in a inversion. And then indeed connecting the lateral malleolus with the talus right there. All these ligaments also have a certain width, so make sure that you scan through these ligaments to see every part of this ligament. Try also to have the ligaments as horizontal in screen as possible. Then we have perpendicular scanning, and this adds to the image quality. That's the ligament underneath effusion that is within the joint, and that is a smooth and healthy bone. Sometimes you can see avulsion signs or calcifications in the ligaments, or maybe at this level of the pointer, joint space gapping or increased effusions. Now we're going to look at the tibiofibular ligament, and like my finger is indicating, this is quite oblique. So from this talofibular ligament, I'm going to sweep the transducer to this oblique position, and then looking at the syndesmosis. And also, of course, the tibiofibular ligament, which can be seen right there. So looking at a few pathology examples, here we can see the fibula and the calcaneus. The ligament should be here, but there we can see a large gap, and with the effusion and of course an interruption of the fibers, no continuity of the fibers, and also for those lateral ligaments, ultrasound scores a 3, meaning it is the preferred imaging technique. So you can see it, it's really well to visualize those ligamentous ruptures. Not only ruptures, but also spraining of or elongation injuries of the ligaments can be seen. The fibers are intact right here, but now we can see a thickening right here. The ligament is a little bit darker, a little bit more hypercoic, and this is due to this sprain. Here we can see a left-right comparison, right having the healthy talofibular ligament, left having the affected talofibular ligament. And the affected side shows itself more hypercoic, swollen, also probably due to a strain. I don't think that we see tearing of the ligament there, but it's more of a ligament sprain. This is an avulsion fracture. We can see that the ligament has torn off a piece of the talus. So we can see this hyperechoic piece, a bone particle. And here we can see that the talofibular ligament has been completely torn. We see a huge gap at the place where the ligament should be. We see also a large effusion coming from the joint and going towards superficial. So this is a really clear, complete tearing of the talofibular ligament. Looking at the talar crural joint, we know that the anterior recess of the tibia of the talar crural joint is there. It's a capsular part where we can see effusions, but also cartilage damage, bone damage, and also signs of spurs. So anterior spurs could be either at this level or maybe here at the tibia level, and this limits also the dorsiflexion range of motion. To look at the talar crural joint, we can make a plantar flexion of the talar crural joint. The joint opens and we can see beautifully part of the talus covered with cartilage. We can see the tibia and also the capsule, the talar crural joint capsule in the middle. On top of it, we can see the tibialis anterior tendon. So going to this slide, look at the transducer placement. It's on the ventral ankle joint, and from there on, we're going to sweep from medial to lateral. Here we can see the capsule, like curtains on the joint, and also with a capsular fringe within the joint. This is the talus. The bone should be smooth. Well, it can be a little bit irregular, but not really damaged, not eroded. And also we don't want to see signs of spurring. And those spurs could also be at this level at the tip of the tibia. So that is what we're going to see and to check. If there is effusion, it pushes up the capsule more towards superficial, and that shows itself, this effusion, more anechoic. And that could be all the way up until there. So joint effusions and synovitis, capsular problems are really easy to see. If it comes to intra-articular problems, that ultrasound is not the preferred imaging technique, and it's best to use other medical imaging techniques. So here we can see the capsule. We can see a small spur right there. And here we can see a calcification. It could be either a calcification or maybe a spur. Anterior spur. So sometimes, and many times, it is also situated in this location. If you do ultrasound guided clinical examination, you can see if this spurs moves along with the talus or not. If it really moves along with the talus, the same range of motion, then it is attached to the talus and it is definitely a spur. Synovitis, we can see a strong effusion right here with the capsule being pushed up, and we can see capsular thickening, synovial proliferation, and lots of anechoic effusion. And then we come to the last part of this tactical scanning and this anatomy, sonopathology, and that is indeed Morton's neuroma, a very clinical relevant condition in podiatry care. And important is to look at the third and the fourth metatarsal bone, and to look in this web space between these two metatarsals. We're going to use the transducer to place it in the middle of these metatarsal bones, shooting to medial to the third metatarsal bone, shooting to the fourth metatarsal bone, and then placing the transducer really in the middle, so that we are really certain that we are scanning the correct place. Then the thumb comes from the from the other side to the plantar foot, my thumb, to the plantar foot of the patient, and then I'm going to do this flexion of my thumb. This pushes the digital nerve to superficial, and if there is a Morton neuroma, it's much easier to visualize.
So Mark, the Morton's neuroma, it's definitely a dynamic exam, right?
Yeah, so
Yeah.
it's important indeed to do it dynamically because this Mulder's click shows you indeed much better the nerve swelling, the neurofibroma than if you would do it statically. So here I'm scanning indeed in the metatarsal web space. My thumb, that is my thumb indeed, is placed to the plantar foot and pushing the plantar foot. Now you can see at the right side of the image, this is my own thumb. So don't be confused by that. So this is my thumb pushing up indeed in the metatarsal web space. And if there is a Morton's neuroma, then you will see the thickening of the Morton's neuroma coming more towards superficial, and in many cases also surrounded with a fluid, which is a sign of a bursa. So this is a example of a Morton's neuroma. So you can see the clear hypercoic thickening, which is a combination of nerve, of connective tissue and fibrosis, scar tissue, and also sometimes some bursal fluid. And here we can see another example of a Morton's neuroma. A Morton's neuroma is really easy to pick up because it's, in many cases, so thick. If you look at a healthy nerve, that is much more difficult to visualize. So in this case, just like a bursitis, if it's affected, then it's much easier to diagnose or to look at than if the anatomy is healthy. So with this, we come to the end of my part. In a minute or in a few minutes, we also have a live Q&A. But if you have more questions after this webinar, you can always send me an email to mark@sonoskills.com, or let's get connected on LinkedIn. You can send me a direct message, or let's meet in person in this ankle and foot ultrasound bootcamp. Thank you very much.
Perfect. I would love to be at that boot camp, Mark. Okay, we're going to hand things over to Janae. She's going to give us a quick demo of the Achilles tendon and the plantar fascia using the same L15 that Mark was using.
Thanks, Shelley. We'll start off our scan by selecting the foot and ankle preset, and I'm going to start at the posterior calcaneus, and we'll start scanning in a sagittal plane. Just increase my depth a little bit here. And here we can see the Achilles tendon pops into view right here on top part of my screen. And this is the insertion site. So the bone here we can see is the calcaneus, and the flat portion of the bone right here is where the Achilles tendon inserts. You can see the tip of the tendon here looks a little bit dark, and that is due to an artifact called anisotrophy. And if we just rock the probe back and forth a little bit, we can get rid of that artifact so that it's not mistaken with a pathology. And the rounded portion here of the calcaneus is an interface for the Achilles tendon and the bone, so it doesn't attach to that portion. So as we move proximally up the Achilles tendon, we can see it lengthen out. It's nice and smooth. The fibers are parallel. If we turn on the MSK-AI here, we can see it highlights the tendon really nicely for us, and we can change the opacity. We can make it darker or lighter. And then when we freeze our image, it automatically recognizes that this is the Achilles tendon. It measures it in the largest thickness. And if we turn off the AI, we can capture the image without the opacity on it there. So we'll move up towards proximal on the tendon, and just deep to the tendon there, we can see Kager's fat pad come into view. And just in this little cove here is where we would see the retrocalcaneal bursa. And if we compress, we can see the fat from that fat pad moving into that bursa right there. It kind of slides in and out. And let's move up proximally. So The tendon starts to thin as we move up towards the calf, and we can see the soleus muscle come into view here just deep to the tendon. And as we move up, the tendon really thins out as it extends into the soleus muscle and also the gastrocnemius muscles, medial and laterally. So we can see it nice and thin. There's the gastrocnemius right here. And we'll come back down in sagittal, assessing, looking for those nice parallel fibers. We don't want to see any bulging out of the tendon, indicating pathology. You can see it nicely right here. All the way down. So if we come back to the heel in a transverse plane, we can see here, these little jagged edges here could indicate maybe the beginning of a little bit of a bone spur. And we'll move up. So there's the tendon nicely in transverse. It kind of ovals out as we move proximally. And if we can use that anisotrophy again. So a normal tendon, when we tilt the probe, turns dark. So we can that indicates that we are seeing the tendon as we rock the probe. So when we're at a 90-degree angle, it's nice and hyperechoic. So we'll scan all the way from distal, proximally, the soleus muscle comes into view there. And the tendon kind of expands outward as it extends into the soleus and the gastrocnemius again. There we go. So now we can have a look at the plantar fascia. I'm going to change my preset to the plantar preset. And this time we're going to come in at the bottom of the heel here. So we can see the fat pad of the heel here, and then just deep to that is where we would find the plantar fascia right next to the calcaneus there. So we can see it nice and bright there. If we wanted to further accentuate the fascia, we could turn on the MSK-AI and increase that opacity, and the plantar fascia really pops there. We can see the borders very nicely in sagittal. And if we freeze again here, it automatically recognizes that we're in the plantar fascia and takes a measurement at the thickest portion of it. And it also displays the measurement up on the top left-hand portion of the screen right here. And if we wanted to adjust the measurements, we can easily move the calipers to wherever we want to and take an image there. So we can follow the plantar fascia as it extends from the calcaneal tubercle all the way to the transverse metatarsal ligaments. Down. We'll turn the AI off here, and we can have a look at this tendon in transverse. So we'll come back to the calcaneus here, and here we can see this bright portion right here is the tendon. And if we push down on the heel, it compresses, and the fat of the heel pad here kind of slides off and delineates the borders of the plantar fascia. And we can move all the way down on it as it comes into you can see the flexor digitorum muscle come in here. I'm just going to darken that up a little bit. Another thing that we can do to delineate the plantar fascia is if you squeeze the heel, you can kind of see that fat pad slide off of that echogenic plantar fascia there, and you can see the borders really well as you go down in transverse. It expands out and thins into those transverse metatarsal ligaments as we move down the arch of the foot. So there we have it.
Great. Nicely done, Janae. Thank you.
Thanks.
Right.
Thanks to both of you, Janae and Mark, for your ultrasound protocols and best practices for imaging the foot and ankle. And before we open the floor to live questions, I'd like to throw out a quick poll. We'd love to help everybody continue their journey into bringing handheld ultrasound guidance to their practice. So Please complete this poll to let us know if we can provide further information, and please click on as many options as apply. And while you complete this poll, I'd like to take a minute to introduce you to the Clarius HD3, our third generation line of portable ultrasound scanners. The HD3 scanners are 30% smaller, lighter, and more affordable. They deliver best-in-class wireless ultrasound, and our linear scanners are unrivaled for near-field and high-resolution MSK imaging and procedure guidance with an easy-to-use app powered by artificial intelligence and connected to the cloud. And today you saw how Clarius supports a confident diagnosis with dynamic, high-resolution imaging of muscles, joints, ligaments, and tendons. And together with artificial intelligence, Clarius scanners deliver the image quality only found in larger systems, larger ultrasound systems, but at a fraction of the cost. You're looking at about an 85% savings. And with AI replacing complex knobs and buttons, it's easy to use as your smartphone. So you can easily diagnose MSK injuries, guide management, and also for safe ultrasound guided procedures like PRP injections. Clarius is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings. You get free movement with no wires getting in the way, which also makes Clarius so much faster to clean and disinfect. We have a special offer for webinar attendees today, which is an MSK bundle, and it includes an L15, which you saw today, and the C3, which is a lower frequency probe. It's suitable for hips, spines, deeper MSK structures. And included is 3-year membership, which gives you access to all the AI and 3 years of Clarius care. And you can scan this QR code here to take advantage of the offer before June 15th. So now that the poll, we'll give it a second here. All right, great. We'll close off this poll here. Thank you very much for completing that. And I do have one last poll. It's an invitation to pre-register so you can join us for our next MSK webinar. It's with presenters who are both doctors of physical therapy, Dr. James Escaloni and Dr. Ian Young. And this will be on the topic of ultrasound-guided dry needling and physiotherapy. So you can complete this poll to save your seat for our June webinar, and we'll send you a confirmation email in the coming days. Great, so now I'd like to welcome Mark back to answer some questions. And we have quite a few here, Mark. So now I could moderate if that's okay with you. Let's see here. Yeah. One of the first questions, and I know you and I are, as sonographers, are very, we realize that ultrasound is very objective, but this one says, I noticed your scan videos are under the MSK preset. Is this the preset of choice instead of using the foot and ankle preset on the L15?
Yeah, that's a good question. Of course, always, if you can use more dedicated presets, then this is always much better. So if you can work with the ankle and foot preset, definitely do so. Yeah.
It's such a personal preference, though, right? Like, I mean, if you happen to like the imaging more on one preset, it doesn't make it wrong. Just, you know.
Oh, but it can be a good starting point, and from there you can go a little bit in that direction or in that direction, but it's a good starting point to work with a preset. Yes, definitely.
Awesome. Yeah. And one other thing I'll mention is that with the foot and ankle presets, that's where you'll see the MSK AI, not with the MSK preset. So it's kind of specific to the application that you're looking at.
I have to say that the AI tool is really cool. Also, the automated really cool. Measurement, it's really fantastic. I think that is a really addition to your flow of working, and it gives you so much extra information. So that is really well done.
Awesome. There was a question about the approach for neuroma exam. Do you ever do a plantar neuroma approach?
The exam I showed, so the Morton's neuroma, that is a technique that I do regularly in clinical practice. I have to say that if you come to the ankle and foot boot camp, We have our best ankle and foot sonographers or sonoscales, worldwide renowned. They will be teaching it, and they will also show you other protocols to teach the neuromas, fibromas. This Muldersklik and this way of using the thumb, that is to me the most easiest way, but it's definitely not the only way. For this webinar, we had to choose a few things, but there's so much more to tell and to show about the ankle and foot. It's a really complex but also interesting region.
What is the best way to inject for a neuroma, dorsally or in between the web space?
Yeah, so that's a good one. So if you would ask me, what do you prefer with me, then I would choose maybe dorsally, because if you really go in the web space, I don't know, to me, it's a little bit ouch, yeah. But in fact, patients prefer to have it in the web space. So practice has shown that it is less painful. So you have to go over, you have to step over over a certain prejudice, maybe, but use the technique in the web space. It's easier and also for the patient less painful.
Do you assess plantar plates with the L15? Can you see enough to grade a plantar plate injury?
So you can definitely see the plantar plates. You can also do the stability testing. Look at so you can definitely see this this plantar plate. Yeah.
Do you ever use elastography function?
Yeah, you know, not so much yet. I use it in the muscle tissues, for example, hamstrings, quadriceps, calf muscles. But I'm also still learning. Yeah, so I'm also still learning. So I'm black and white, Doppler, diagnostic, interventional, all okay. Elasto is also, for me, still on the learning curve.
This appears to have such a steep learning curve. I don't see any way to learn this other than to have you right beside me and guiding me. Where is the boot camp?
I can hold your hand. Yeah. So you know, ultrasound is easy to learn and hard to master. So I think that if you come to the boot camp or if you follow other courses at other locations, the sonoanatomy that is easy to learn. I think in a couple of days, also in this 2-day boot camp, then you can learn lots of sonoanatomy. And then the hard part comes afterwards if you need to learn pathology recognition. And that you only learn by doing, not being afraid of making a mistake. Just do it, and we can help you with that. We also have a free website, ultrasoundcases.info, with lots of pathology cases. It also helps you in your steepening your learning curve. But also in our course, which is combined with e-learning. So you get e-learning, you can prepare for the course, and you can complete the course afterwards also with some extra videos. And of course, the hands-on course where with a maximum of 3 people on a system, and you learn scanning on models with expert faculty. And this course actually is in Amsterdam in the Netherlands. It's a short flight from the East Coast of the US and Canada. So it would be really nice to meet there. And the course is also in English language.
Mark, what's the normal thickness of the plantar fascia?
I saw that Janae was scanning it with AI. I saw the automated measurement. I thought it was like 2 to 3 millimeters. So I have to say that usually I do left-right comparisons. I eyeball it, and then I measure in person. That is the way I do it. I think that with the new software, that this one helps and does it with the AI tool, I would use it definitely more. because it's an easy step to use it. But I have to be honest that I don't have a whole list in my mind with every structure which is with its cutoff value, healthy versus not healthy. So I always do left-right comparisons, many left-right comparisons.
I think it's under 4, under 4 millimeters.
Sorry.
Thanks, Janae.
Thanks.
Yeah.
Is there a visible difference on ultrasound when assessing gout crystals versus pseudo-gout versus hydroxyapatite crystals?
Yes, so you can definitely, in the rheumatology population, you can also use ultrasound. And with gout or pseudo-gout, that is indeed difference. For example, with CPPD, you will see some cartilage changes, that in the middle of the hyaline cartilage, you can see a hyperechoic change. So the hyaline cartilage is anechoic, and in the middle of the cartilage, you will have like these crystals in the middle showing itself hyperechoic. In gout, you won't see that, but then the top layer of the cartilage is different and is more hyperechoic. That is how to differentiate CPPD or pseudo-gout with gout. Yeah, so that is how you could look at that.
Do you ever use ultrasound to assess plantar ulcers?
I work in a radiology setting, and I have to say that I don't see that many plantar ulcers. But in the e-learning we offer, and also in the hands-on course, this course is being taught by a podiatrist, and this topic is also being covered there.
Yeah, there's just a couple more questions about the dates of your course, Mark, and
yeah, so it's early July. So if you go to sonoskills.com, it is a course which is being organized once every year or once per half year. But the next edition is indeed in July, early July.
Great.
You can combine it with a nice visit to Europe and to
totally
Amsterdam City. It's always nice to be here.
All right, good. Okay, so I think to be respectful of everyone's time, we're just over the top of the hour here. So thank you all for your questions. A lot of you asked for more information. On our Clarius website, in the education tab, you'll find access to the library of on-demand webinars and classroom video tutorials that Mark showed today. And just another reminder that you will all receive a PDF copy of the slides and a webinar recording for today's session. So thank you so much, Mark, for sharing your best practices.
Thank you.
And thank you, Janae, for the great live scanning demo. And a very big thank you to all of you for joining us. We hope to see you again on June 19th to explore physical therapy applications. So until then, keep scanning, and we hope you have a wonderful rest of the day.